welcome back to EM Board Bombs. What's up, Briggs?
Just happy to be here. How are you?
Joined by
nice Sunday podcast recording.
I know. Sundays are always just a bit wild, at least in the Husain household. I'm sure they are in the Briggs household as well,
Yes.
yeah?
Yes.
So, Briggs, today I'm really excited about our topic because it's something that I can almost guarantee every single person listening to this treated a patient with on their last shift
Yes.
or their upcoming shift. So when it comes to, we've talked about other things like cerebral venous thrombosis or like other things, and you're like, all right, VTAC.
Yeah. But, hydralazine, our favorite.
Oh my gosh. The hydralazine post has now got almost 200,000 views on Instagram. My gosh. I guess that's what the young kids call going viral. Is that right? Like I have like random residents, nurses coming up to me about the hydralazine posts. Like the makers of hydralazine are after you, by the way. So you better watch yourself, Briggs. Take the appropriate safety precautions.
From a covert location.
Covert location. Basically, we were knocking hydralazine in that post on Instagram. If you haven't seen, it's got almost 200,000 views. IV. Yeah, PO, we were not knocking. It was IV. There's so many clarifications we had to make. I mean, there are like hundreds of comments on that post, but moving on. So we're going to get into a post here.
EM Board Bombs.
Yeah, EM Board Bombs.
Blue Collar Podcast.
Yeah. Blue Collar Podcast. Hey,
co-founders.
Let's go ahead and start with that stem.
Yeah.
You're working a busy ED shift when a 67-year-old man named Earl is brought in from a, quote, wellness retreat. He's febrile to 101.8, mildly tachypnic and complaining of cough and fatigue. His daughter says he's been coughing for 2 weeks, but he refused to see anyone because he read that antibiotics are a big pharma conspiracy. She says he also has only been popping ibuprofen and now his stomach hurts from that. She says that we cannot use any Tylenol for him. Shifty eyes here. You do your usual ED workup. You get a chest x-ray, shows a right lower lobe infiltrate. On exam, he's stable, alert, and he is eating organic, farm-to-table, artesian kale chips during your exam. His vitals are respiratory rate 20, blood pressure 130/80, heart rate's 95, O2 sats 95% on room air. Past medical history is hypertension, but nothing else. You diagnose community-acquired pneumonia, CAP, and prepare to discharge him with antibiotics. Just as you're finishing your note, his daughter says, hey, by the way, we're going to his wellness spa again tomorrow, also known as the Citadel Nursing and Rehab floor. So he's going back to his facility. All right, you
it's the longest question in the world.
I know, right? What change should you make to his antibiotic regimen before he checks in or checks back into his nursing facility? Is it A, add Vinco and cefepime for MRSA and Pseudomonas coverage? B, switch to Augmentin plus azithromycin. C, start meropenem and linezolid because he's clearly circling the drain. Or D, no change. His pneumonia is still considered community acquired. Briggs, what's the correct answer here?
Sometimes simple is better. Correct answer here is choice D, no change. It's still CAP. I love this question.
I do too, because there's been a Cite change of things that have happened here. And back in the day, it was like, oh my God, nursing home. Well, we're going big guns, right? And that's what this was trying to really hammer down.
Dialysis centers. Yeah.
Exactly. Yeah. And hey, Rapid Bombs boards are coming up. Check it out.
Happening right now.
Yep, happening right now.
Not too late though. Not too late for you.
Not too late for you. You can get 3 to 5 minute long episodes delivered to you along with multiple emails a week with pearls. Great way to study, great way to learn. Check it out. You can go to emboardbombs.com, look for the question bank that we have. It's the only audio Q bank. So great way to have focused learning. So Briggs,
thousands of subscribers on that now.
I know, it's pretty amazing. Pretty amazing. Yeah, great community, right?
Yeah.
Hey, so Briggs, let's talk about this, because this is a big thing, right?
Yes.
Because again, there have been some Cite changes. We are going to focus a bit on obviously some of the evidence and some of the antibiotic strategies, and in usual EM Board Bombs way, try to keep it blue collar, essentially giving you like patient scenarios and dispositions and what you're going to be doing for antibiotics, right? I would say a key caveat to this is understanding your sensitivities of antibiotics in your local area, what your medical center
course.
practice is as
Yeah.
well. So that's really important. So take what we say with a grain of salt, if that makes sense, right, Briggs?
Absolutely. Yeah. Yeah. So what's interesting about pneumonia is that it used to be 100%. It's so funny how we've backed off more and more off pneumonia. You know, like 20, 20 years ago, it was like admit every one of them. And 10 years ago, it was admit the ones from nursing homes and dialysis centers. And now it's like, don't even do that. Uh, Now it's like, are antibiotics even needed? That's a whole different debate. Anyways, pneumonia is considered hospital acquired only if it develops greater than 48 hours after hospital admission. And same with VAP, ventilator associated pneumonia. It's greater than 48 hours. And the big thing with this is going to be you're going to stick with community acquired coverage in this patient, this guy named Earl. And that's going to be either high dose amoxicillin or doxycycline. You can think about changing that to augmentin, which is amoxicillin plus clav, or azithromycin, adding that in.
Adding it in.
If they
That's the
have
key.
some comorbidities, but we'll talk about what that means and what HAP and VAP are and all that. But hey, the first thing about pneumonia is that we usually misdiagnose community-acquired pneumonia a lot of the time, up to 1/3 of the time.
Yep.
And the reason is because there's a lot of mimics for pneumonia. You know, we'll look at the X-ray and think, hey, that looks like pulmonary edema, that's CHF. I got to diurese them and admit them, and then you know, they are inpatient, they linger for a few days, and then they finally spike a fever, and you're like, whoops, need to give them antibiotics too. And, you know, PE can sometimes mimic it. They're short of breath, hypoxic, whatever. And then, of course, you have viral infections, most classically.
And who's reading the images? Well, not just kidding. Anyways, moving on.
Yeah, it depends what year they are. So the chest X-ray sensitivity is also imperfect. It depends so much on the angle. Is it a 2-view? Are they sitting upright? Is it the semi-upright, as I like to say, in certain parts of the ED when it's a bedside X-ray? And they semi-recumbent? And there's really no single historical or physical exam finding. And this question, as funny as it was, let's be honest, pretty straightforward. Fever, cough, respiratory symptoms, and an X-ray finding of an infiltrate. I love when I see that because I even like go around showing people, like, look, it's a lobar infiltrate. Look how easy this is for once. And of course, the labs aren't really helpful. I know we're trying to chase all these procals nowadays, or internal medicine is at least. And then CRP,
We're
ESR.
not, to clarify.
And, yeah, I said, that's why I said another specialty.
I know.
For us.
This is great.
And the white blood cell count, which everybody likes to talk about. All these things are just not that helpful. So just put that on your mind. And the triad here of fever, respiratory symptoms, imaging evidence, I think is the big thing to go back on. So often I'll have students or residents say, hey, well, they have a fever, respiratory symptoms, but their imaging is negative, but I still think they may have pneumonia. I'm like, well, how are you explaining that? You know, and it's hard in certain patients. And that's, in general, pneumonia is a radiographic diagnosis. However, there are some special populations, really dehydrated patients, really old patients, neutropenic patients or immunocompromised patients, even if they have a quote unquote normal X-ray and some like ground glass opacities or whatever, that can be concerning for pneumonia. So always be cautious.
Briggs. So even on a normal chest X-ray, you're not necessarily ruling
the
out
subset
pneumonia.
Population.
What is that subset population? Let's name him. Let's go. 1.
Yeah. So the very old, the very sick,
3.
and then the immunocompromised, like neutropenic patients.
Exactly. And lastly, it's really kind of early onset as well. So that's great.
Exactly. Yeah, of course. Yeah.
Really remember that population.
Yeah. So why don't you dive into, let's say you make the diagnosis. We can't really help you with the weird X-ray findings here. Good luck out there. Hopefully it's straightforward for you when you make the diagnosis. But let's say when you make the diagnosis.
Godspeed.
Yeah. Good luck. When you make the diagnosis, now you're going to talk about the next steps of disposition, right? And so why don't you dive into that in terms of some scores, in terms of some clinical criteria, and, basically who goes home, who needs a bed, who gets ICU, which is usually the more obvious ones.
Yeah, this is like the great one where it comes in, or like the ICU one's kind of like the easy one, where it's like,
yes,
they're
of course.
definitely coming in. They're like hypoxic on oxygen.
Yeah, easy.
But when do I bring them if they're not on oxygen? Like what is that? So who goes home? Who gets a bed, right? Who gets the ICU? So we recommend the Pneumonia Severity Index score as the risk stratification tool of choice over the Curve 65. So that's really important. Better than the Curve 65. Why? So it's more sensitive for identifying patients needing ICU, and it's better at mortality prediction. Some might want to use that Curve 65, though, if you want to try to get that patient admitted, or you need a reason.
Just depends.
Reason for it. So the Pneumonia Severity Index is, look, it's not perfect, right? It may underestimate severity in younger patients. It doesn't account for social factors as well, like poor home support, compliance with medications, things like that. The Curve 65, again, can still be used kind of as this quick bedside score if you want. It's decent, right? But again, we would recommend the Pneumonia Severity Index score. It's a bit more sensitive. A couple of key things that are just like baseline understood, not including these scores, right? I alluded to it at the beginning of this. What are some of those key things?
I think this goes for any patient in general with an infection.
Yeah.
But it's going to be respiratory rate less than 24, oxygen saturation greater than equal to 92% on room air, normal mental status, of course, able to take PO. That would help if you're discharging them with antibiotics. And then adequate social support, meaning that it's not a 97-year-old frail elderly person with pneumonia you're sending home alone. That would be a little bit sketchy. And they can barely walk to the bathroom. That's probably not a good idea. So if any of these are hitting not those, met,
you're basically doing what? What do
you're going to admit these patients.
Yeah, there you go.
The oxygen saturation is the biggest one, especially if it's a new onset. They look great otherwise. It's still something's not up there.
Yeah.
Something's not right. So your decision tree is the patient if they're low risk, which is a PSI less than or equal to 70, or if you're using the curve 65, 0, or 1. And, they meet all those minimum criteria we just said, then you can strongly do outpatient. You should be doing outpatient therapy for these people. If they're higher risk than what we just said, or they fail those minimal criteria we just talked about, they should go inpatient. They should stay a minimum of an overnight, and it's totally fine. And if there are major criteria, like, we didn't really go over this, we don't need to, but any sort of septic shock, any sort of requiring Optiflow or all these things are just
so you're saying you're not applying the PSI and the curb 65 score to the patient on high flow.
Listen, let me just be clear about something. If they're intubated, they should probably go to the ICU. So just saying.
Can you imagine that sign out to the ICU? Hey, I've got the sign out for you, ICU patient, pneumonia. Why do you think they require the ICU? What's their
they're intubated.
What's their PSI score? They are intubated.
It's like GCS3T or whatever it is. Yeah.
Gosh.
Yes. Your favorite score. Hey, let's dive into the outpatient management. So what are the guidelines here in terms of antibiotics? This is like kind of the gold section for people.
I love
listening.
this. Yeah,
I think really simplified.
This is important. This is really, really important. We're going to keep it simple. We're going to keep it blue collar. We're not really going to get into the subtleties. We're really just going to try to avoid that. So most folks, they recommend good old amoxicillin. 1,000 milligrams, PO/BID, first line, in outpatient without comorbidities, right? That's the key.
Perfect.
Right. I can't even pronounce comorbidities, but yeah, there you go.
Still great.
So if you're allergic to penicillin, what's the key?
Doxycycline.
There you go, doxycycline, right? So amoxicillin is fantastic. It really is. It's underutilized, I think, and you really should use that as first line for your outpatients who do not have significant comorbidities.
Yes.
So Augmentin, it can be considered as an alternative as well, especially in patients with poor. Yeah, exactly. And that's just basically a amoxiclav, right? And those are in patients with poor oral hygiene or they're at risk of beta-lactamase producing organisms.
What that even means, translated?
Yeah, why don't you explain it?
Yeah, I mean, just simplify. I mean, what do you even define by that? I would just say the patients that you're flirting with admitting, maybe. That's probably the patient you should do augment to. You're never going to be tested on that. You
really are. Yeah. But so
what you are going to be tested on is this next thing.
I know. And this is huge. I honestly think it's pretty big, right?
Yes.
So most experts basically are skeptical about adding routine azithromycin, right? So macrolides to all patients. You can cite a 2014 JAMA trial that basically showed that while addition of macrolide shortened time to clinical stability, it didn't actually improve patient outcomes, which is like the most important thing, mortality. They also cautioned that, I remember hearing this in like med school all the time and like even early in residency where there's like this anti-inflammatory effect of azithromycin and that doesn't really have a strong evidence to support it. I wonder who started that, by the way. We should probably do a deep dive into that. Actually, no, we're not going to do it. Yeah, it's probably a company that made it. They're like, it's not really working. They're like,
I was always told
it's anti-inflammatory.
I remember one time when I was working in pediatric ER, the family bounced back because they were given an antibiotic for pneumonia, and I said, "What were you given?" And the parents said, "We were given this antiviral azithromycin."
Yes. The antiviral azithromycin, so except funny. That is in reality, I think how it's used.
Did you hear it treats coronavirus? Yeah.
That's how it's used. That's the easiest tell, like to anyone in healthcare, when a friend will say, when you ask a friend, you're like, hey, what ended up happening to you for this cough or this, like, I don't know, runny nose of like 2 days, right? And they're like, oh no, I got something. they think it's a pneumonia. I'm like, oh, okay. I got azithromycin.
Yeah,
And I'm like,
exactly.
yeah, I know
Or they
how
come in,
serious.
yeah, they come in, they're like, I haven't been getting better, and I'm like, oh, what antibiotic were you on? It's
Yeah.
I'm like, okay, well, that
There
makes
you go.
sense.
It's
But
like two lines, right? It's like
yeah,
one utilized by the provider who just wants to get the
yeah,
patient, like, okay, going with the azithromycin, or two, just
yeah,
inappropriately utilized
yeah.
as well.
Yeah,
Anyways,
and it's funny because there actually is, it is sometimes used to empirically treat Legionella in certain seasons and risk
sure,
factors for Legionella. And
sure.
there was this meta-analysis in 2022, and it was 6 randomized controlled trials, and they found that doxycycline was pretty much just the same
Yeah,
to macrolides and
yeah.
fluoroquinolones, and it's lower cost, shorter hospital stay, definitely less side effects than fluoroquinolones. And so this, in general, supports doxycycline as a really solid choice
Really is.
in patients with non-severe community-acquired pneumonia and no other risk factors. And so that's a fantastic option. Now, one key point here is that this goes for almost any antibiotic, really, is that oral antibiotics are the same as IV in general
Yeah,
in terms of the bioavailability,
right.
the recovery rate, the outcomes. And so you're not admitting the patient for quote unquote stronger antibiotics. When you're admitting the patient, we talked about earlier, it's because of their clinical status, not because they're going to get better antibiotics within 24 hours. It's not true.
Yeah,
At
and
least
Briggs, I got to
9
interrupt
randomized
you.
control trials show
I
that.
got to interrupt you for something here.
Please, go ahead.
You brought my PO and IV, right? When you are discharging someone with PO doxycycline, and this is just a rant, I have to go on, Briggs. I'm sorry, hold me back
It's
here.
okay. I'll hold
But
you back.
you need to tell patients to take PO doxycycline with food. Please, please do not tell them to take, they're not feeling well already. Oftentimes these
Mhm.
people aren't eating, drinking as much, and then they're just given PO doxycycline, not told that they need to take it with food. I mean, it tears apart your gastric lining, causes tons of irritation. And I literally have had folks come into the ER. You see this in the community too. Oftentimes, is they're just having terrible stomach upset, or they feel like they're having a heart attack even sometimes. And you're like, wait, you were just started on some antibiotics for like a
Exactly.
pneumonia, and they're like, oh
Yeah.
yeah, doxycycline, and it's like, oh, are you taking that on a full stomach or with food? No, not at all. And then the
Never.
worst is that combo of
Yeah.
like doxy plus steroids. Now they're taking doxy plus they're taking a steroid, just ripping apart their stomach. So
Yes.
again, please, that is like my tangent. If there's one of the main things to take away from this episode is, please, always when prescribing doxycycline, educate your patient
Totally.
that they need to be taking it with food on their
Cool.
stomach. Moving on.